Okay, so let's move to the second topic. It is the imaging anatomy and pathology of the orbits. And this is presented by our distinguished speaker, Dr. Pattana Wangaryattawanich. He graduated from King Chulalongkorn Memorial Hospital, Chulalongkorn University, Thailand. And now he is working as a neuroradiologist at the University of Washington School of Medicine, Seattle, USA. And what I can notice from his CV is he's got awarded of the Neuroradiology Teacher of the Year 3 years in a row. So please welcome Dr. Pattana.
Thank you, Dr. Thanwa, so much for your kind introduction. And first of all, I would like to extend my sincere thanks to Dr. Thanwa and also the organized committees for this meeting, for this kind invitations. It's just such a great honor to be here and have an opportunity to share my knowledge with you guys today. So let's get started. The topic that I got assigned today is my talk is about imaging anatomy and pathology of the orbit. So I have nothing to disclose. And so I can divide my talk into two main sessions. So first, I will be reviewing the anatomy of the orbit. So at the end of my talk, you should be able to, you should understand the detail of the structural components of the orbit. And then later on, in the second part of my talk, we will be exploring some common and uncommon pathologies at the orbit based on using the practical imaging approach for orbital pathology. So overview of the orbit. Orbit is like the conical to pyramidal shaped recess that located in the face, and it contain a lot of soft tissue or structural components that responsible for visual function of our body. It can be divided into two distinct soft tissue components, including the first one is the eye globe, also known as the ocular structure. And then the second component is orbits that include other structures except the eye globe. So we have bony orbit, we have preorbital, we have extraocular muscles, multiple nerves, we have cranial nerve 2 or optic nerves, and we have other cranial nerves that supply the extraocular muscles and also autonomic nervous system. We have some supporting connective tissue, including blood vessels, adipose, and connective tissue. And lastly, we have lacrimal apparatus. So let's start from the bony orbit. So bony orbit is pretty complex. Bony structures is formed by 7 different bones. But I think it's not important to be able to, that we don't have to memorize all these 7 bones. But I think it's more important for you to recognize the anatomic landmark that will help you when you encounter a patient with orbital pathology. So let's start from the 12 o'clock at the top of the orbital roof. So first you will see that at the top of the orbital roof, just medial to the 12 o'clock of the orbit, is the location of the supraorbital notch. So supraorbital notch is the tiny notch that you have supraorbital nerve, which is branch of the cranial nerve V1 that will run along the roof of the orbit. And when it exits out from the orbit, it will pass this tiny notch and then supply the sensory function at the forehead. And then we move inward along the supromedial aspect of the orbit. That is the location of the trochlea fovea or trochlea fossa. So trochlea is the fibrocartilaginous ring that hook the tendon of the superior oblique muscles. And it will locate just right there. There is a tiny small depression at the supromedial of the orbit. And oftentimes, you will see physiologic calcification in that fibrocartilaginous structure. So it's very important to understand that we will be able to see physiologic calcification in this area. So sometimes patient got CT orbit for MRI clearance to see if there is any radiopaque foreign body in the orbit. So sometimes it's mistaken as a retained foreign body, or even in the trauma setting, sometimes it can be mistaken as a small microfracture or small bony fragment. And when we move down into the area of the mid portion of the medial orbital wall, you will see that there are two teeny tiny foramina that is anterior and posterior ethmoidal foramina. So in this illustration, you will see that it's just located right around in the just above the mid portion of the medial orbital wall. And we're able to identify these structures, and it's kind of more relevant when we interpret CT sinuses. I will show you on the next slide how to identify them. And then downward here is the location of the lacrimal groove, that is the where lacrimal sac reside. And then at the area of the orbital floor, just below the orbital floor, you will see that we have the infraorbital canal or foramen. And that is where infraorbital nerve that traverse exit from the orbit and supply the midface. And then lastly, we have the lacrimal fossa at the supralateral portion of the orbit, and that is where lacrimal gland is sitting. So this is another illustration to show you that we have anterior and posterior ethmoidal artery, which there are branches of the ophthalmic artery. When it branch off from ophthalmic artery, it will exit the orbit through this foramina, and then it will provide arterial supply to the area of ethmoid sinus and also the superior aspect of the sinonasal cavity, including the superior nasal septum. So this is coronal CT of the sinuses and the orbit in bone window. So when we move anterior, so we look at the mid portion of the orbit. So when you want to identify the anterior and posterior ethmoidal artery foramina or notch, so look at the junction between the medial orbital wall and the roof of the orbit. It's just right at the superior aspect of the lamina papyracea. When you slice on the coronal plane, you will see that we start to see it's like a tiny triangular shaped notch at the junction between lamina papyracea and the orbital roof. So that's where you will find the anterior ethmoidary notch. So this anterior ethmoidary notch is related to one of the anatomical variation of the sinus. So look at the right side. So you will see that the ethmoid sinus on the right side, it just stops right at the level of the anterior ethmoidary notch, right? But when we move to the left side, you will see that this notch, and then you have extension of the ethmoid air cells above the anterior ethmoidary notch. So this is this variation we call as the supraorbital ethmoid air cell or supraorbital pneumatization. So when ENT surgeons perform endoscopic sinus surgery, including ethmoidectomy, sometimes they want to get the complete ethmoidectomy, but they should be aware of this anatomical variation in that patient that they operate on. Because sometimes they try to get above the anterior ethmoidary notch in the patient who have this anatomical variation, and then they dissect that artery. So anterior ethmoidal artery can get retracted after dissection and then back into the orbit, and it will cause intraorbital hematoma after endoscopic sinus surgery. So this is very important anatomic variation, and we always check this in our CT sinus, especially for CT sinus done for preoperative planning. Okay, so next structure is orbital fascia or preorbita. So basically it's the periosteum of the bony orbit. So look at this illustration, you will see that we have in the intracranial component, we have dura mater. And then right at the level of the optic canal, dura will split into two different layers. So we have preosteal layer of the dura that form the preorbital or orbital fascia along the wall, bony wall of the orbit. And then the second layer is the meningeal layer of the dura, and that will cover the intraorbital optic nerve. So and then in the anterior aspect of the orbital fascia, it will, in continuity with this structure, that is the orbital septum. So orbital septum will attach to the aponeurosis of the tarsal plates of the upper and lower eyelids. And orbital septum acts like a barrier between the anterior periorbital tissue and the intraorbital tissue. And this is the structure that we use in the classification of orbital cellulitis into pre-septal and post-septal orbital cellulitis. Because if inflammation still confine anterior to the orbital septum, that is classified as pre-septal cellulitis. And if infection progress, it can spread through the orbital septum back into the in the posterior aspect of the orbit, and that will classify as a post-septal cellulitis. Okay, next structure is the eye globe. So eye globe is a very unique structure, and it has along the wall is comprised of 3 layers. So start from the inner to outer, we have retina, and then we have choroid at the middle layer, and then the outermost layer is the sclera, which is mainly comprised of the fibrous tissue. So in the eye globe, it can be divided into 2 segments using the ciliary body. So if you look at this illustration, we have ciliary body that attach to the lens, right? And then you use this structure to divide into anterior segment and posterior segment. Anterior segment can be further subdivided into anterior chamber and posterior chamber, and using the iris. And if you perform a high resolution T2 weight image, you should be able to identify the iris, and then you see that this area is going to be area of the anterior chamber of the anterior segment, and then this area is going to be posterior chamber. And then posterior segment have only one component, that is vitreous chamber. So when you inject contrast and acquire T1 weight image, you will see that there is a thin, smooth line of enhancement along the wall of the orbit. And the only layer of the orbit that show enhancement is the choroid, it's the uvea that can show enhancement. So retina and sclera do not enhance on post-contrast T1 weight image. So what you're seeing here is the enhancement in the choroid, and then the outermost layer that show no enhancement, that is the area of sclera. Next is extraocular muscles, and there's innervation. So extraocular muscles, we have 7 muscles, including 4 rectus muscles, 2 oblique muscles, including superior oblique and inferior oblique. And then lastly, we have 1 levator palpebrae. So all extraocular muscles originate from the common tendinous ring at the orbital apex, and it's so called as the annulus of Zinn. And this is, so all EOM will originate from this tendinous ring except for the inferior oblique muscles. For innervation, the oculomotor nerve or cranial nerve 3 is the main nerve that supplies most of the extraocular muscles. So when cranial nerve 3 enter the orbit at the orbital apex, it will split into 2 main divisions. So we have superior division that supply levator palpebrae and superior rectus. And then we have inferior division of the oculomotor nerve that will supply medial and inferior rectus muscles and inferior oblique muscles. And then cranial nerve 4 supply superior oblique muscles, and cranial nerve 6 will supply lateral rectus muscles. So on this illustration, you show you a nice anatomy of this all EOM that start from the annulus of Zin at the orbital apex. And this is the illustration that show anatomy of the superior oblique muscles that, again, there is a trochlea at the superomedial aspect of the orbit, and that is where fibrocartilaginous ring of the attached to the trochlea fovea. And then superior oblique will attach to the superolateral aspect of the eye globe. And inferior oblique muscles originate from the infromedial aspect of the orbit and then attach to the infrolateral area of the eye globe. Now move on to the orbital apex. This area is pretty complex and is formed mainly by the optic canal and the superior orbital fissure. So look at this bony anatomy of the orbital apex here. You will see that we have optic canal where the optic nerve exit the intracranial compartment and enter the orbit. And then we have superior orbital fissure located right here, and these two separate by a small bone knee structures. We call this structure as the optic strut. So optic strut is the part of the sphenoid bone, and you can identify this on CT scan. And this is illustration to show the anatomy of the orbital apex and also the annulus of Zinn. So you see that annulus of Zinn is formed by 6 EOM out of 7 EOM. And then the optic nerve will exit through the optic canal. And then the superior orbital fissure will located right here, and then we have inferior orbital fissure that in continuity with the SOF. Anatomically, superior orbital fissure can be divided into 3 individual sections using the annulus of Zinn that we have here. So you have superolateral section of the superior orbital fissure. We have central section, and then we have the inferior section. So each section is we have a separate nerve that traverses through that area of the superior orbital fissure. For example, in the superolateral section of the superior orbital fissure, you have cranial nerve 4 and 2 branches of cranial nerve V1, including frontal nerve and lacrimal nerve that traverse through this area of the SOF. And in the central portion, we have cranial nerve 3 and cranial nerve 6 and 1 branch of the cranial nerve V1. So as you can see in this illustration, that cranial nerve 3 split into superior division, inferior division, and we have cranial nerve 6 that sitting just medial to the lateral rectus muscle, and eventually it will innervate the lateral rectus muscles. And then we have a teeny tiny nerve that is the nasociliary nerve, which is branch of the cranial nerve V1. And then in the inferior section of the SOF, we have only one structure that is inferior ophthalmic vein. And then we have cranial nerve V2 that exit through the inferior orbital fissure. Okay, next structure is optic nerve. So optic nerve is pretty unique and is a little bit different from other cranial nerves. So optic nerve is like an extension of the brain that connect the brain into the globe. So optic nerve can be divided into 4 different portions. Start from the front, we have intraocular segment of the optic nerve, which is like a very short segment of the optic nerve just right around the area of the optic disc. And then you have intraorbital segment of the optic nerve. We have intracanalicular segment of the optic nerve, which is optic nerve that traverses through the optic canal. And then last segment is the intracranial segment of the optic nerve, is where optic nerve sitting in the subarachnoid space inside the intracranial compartment. And look at this microscope picture, you will see, I want to show the appearance of the intraocular segment of the optic nerve. So neuron that accumulate right around the area of optic disc, that's come from retina. And then these neurons will kind of condense and wrap around by the tiny, like a thin fibrous ring in that area. So you can see that it's kind of like a small wedge right around the optic disc. And that is called lamina cribosa. And then in the more distal portion of this optic nerve, that is the beginning of the intraorbital optic nerve. And right in the central area of the optic nerve, you will see a central retinal artery that traverses to the substance of the optic nerve. So for around the optic nerve, you will have subarachnoid space and also the arachnoid membrane, pia mater and dura mater that wrap around it and form the optic nerve sheath. And for arterial supply, I think it's pretty interesting, and we should understand the arterial supply of the optic nerve, because when they discuss about in neuro-ophthalmology conference, sometimes we have patients that have ischemic optic neuropathy, so we understand what we are talking about. So intraorbital optic nerve has a different, in the different area of intraorbital optic nerve, has a different arterial supply. So let's look at in the area of right around the optic canal and the proximal portion of the intraorbital optic nerve. You will see that this area is supplied by two main vessels. So first one is hypophyseal branches of the ICA. So it's the small branch of ICA that penetrate inside the optic nerve. And then second arterial supply in this area is come from PL branches of the ICA, which is like a small branch that run along the pia mater of the optic nerve. And when it supply the optic nerve, you will see that it's branch off and give rise to the small perpendicular branch and penetrate to the substance of the optic nerve. In the mid portion of the intraorbital optic nerve, there's only one arterial supply, and that is PL branch of the ICA. In the distal portion of intraorbital optic nerve and intraocular optic nerve has a more complex arterial supply. So it also receive blood supply from the PL branch of the ICA. At the same time, there are two other branches. One is the central retinal artery that take off from the ophthalmic artery. And then last one is the short posterior ciliary artery that also is the distal branch of the ophthalmic artery. So based on this different arterial supply in the optic nerve, you can divide optic nerve into anterior optic nerve and posterior optic nerve. So when patients come in with sudden onset of visual loss based from the ischemia of the optic nerve, neuro-ophthalmologists will divide it into two main types that include anterior ischemic optic neuropathy and posterior ischemic optic neuropathy. So anterior ischemic optic neuropathy is pathology that occur in the area of the short posterior ciliary artery. So it's caused by occlusion of these vessels, and thus it will cause ischemia in the area of intraocular segment and the adjacent intraorbital segment of the optic nerve. And when they perform fundoscopic exam, you will see that there is swelling of the optic disc. So that is represent one of the features of the anterior ischemic optic neuropathy. For posterior ischemic optic neuropathy is occurred by the occlusion of the PL branch of the ICA. So it will occur right around in the mid portion of the intraorbital optic nerve. When neuro-ophthalmologists perform fundoscopic exam, you will see that the area of the optic disc will look normal. So that is the main difference between these two. And another separate disease entity is occlusion of the central retinal artery, and that usually caused by emboli that throw into the central retinal artery. So last structure in the orbit is the lacrimal apparatus. So we start from lacrimal gland that located at the superolateral aspect of the orbit. So tear will produce by this gland and excrete through the small ducts just located at the deep surface of this gland, and then will traverse the conjunctiva into and accumulate right around the area of the lacrimal sac. So it's drained from the conjunctival surface into lacrimal sac through the small canaliculi, and that's common canaliculus. And then eventually tear will pass from lacrimal sac through the nasolacrimal duct and open into the infra nasal meatus. So lacrimal gland can be divided into two lobes using the aponeurosis of the levator palpebrae. So in the outer portion of the lacrimal gland here, that is the orbital lobe of the lacrimal gland. And then the deeper lobe is the palpable lobe of lacrimal gland. And if you perform and get a good quality of MRI of the orbit, and you look at the coronal plane, you will see that on this cut, we have a levator palpebrae located right there. And just below it, that is area of superior rectus muscles. And then levator palpebrae has aponeurosis that extend into the area of lacrimal gland. And if you look at the lacrimal gland very carefully, you will see that there is a thin linear filling defect inside lacrimal gland. So that is the structure that divides lacrimal gland into orbital lobe and palpable lobe. Because of anatomy of lacrimal gland that have a small duct open along the deep surface of the gland, when surgeons perform biopsy of lacrimal gland, they will avoid to do biopsy that can cause injury to the deep portion of the gland because it can occlude the duct. And eventually it will destroy the lacrimal gland. So when they perform biopsy, they tend to avoid to do biopsy right around that area of the gland. They will aim to biopsy the orbital lobe of lacrimal gland. Okay, so we finished the first part. So now we move on to the second part. When we encounter patients who have orbital pathology on imaging, how should we think about it? So this is a pretty important concept when we want to approach patients who have orbital pathology, and that concept is orbital compartments. So that means orbit can be divided into 6 different compartments based on the anatomy. So start from the eye globe. That is a pretty separate and unique structure. That is one thing. Today we're going to focus on the pathology that occur outside the eye globe. Second compartment, we have bony orbit, right? So this is the bony wall of the orbit. Next is extracorneal space. So basically we use the rectus muscles and intermuscular septum that form like a cone inside the orbit. And we call that one as a conal space. So space that's located between conal space and the bony orbit, that is area that we call as the extracorneal space. And then the space that's located inside the cone or the conal space, that is intraconal space here. And then last space compartment that we have is the optic nerve sheath complex. So today I'm not going to show you the long list of potential pathology that can occur in each space, but I have a recommended reference that you can review at your own time, right? So first we have one of the most recent publications on that published in radiographics from last year. And it's a pretty good summary of the practical approach to orbital lesions by anatomic compartments. And if you kind of old-fashioned studier, a student like me, I like to review the textbook sometime. And I still use this as kind of our head and neck radiology standard textbooks written by Dr. Som and Dr. Curtin when I want to review in detail about anatomy of head and neck structures and the pathology. So we're gonna explore some pathology based on the real patient that we have today. So first we have a young man who come in with progressive left proptosis and swelling over the left eyelid for 2 years. So initially he got CT scan, and I'm showing you the CT in bone window in coronal plane, axial plane, and sagittal plane. And you can see that this patient have a pretty large lesion that center at the superior orbital wall or orbital roof, and it shows as an expansile lytic osseous lesions. And inside the osseous lesions has like a pretty nice multiple internal septation, and somehow it kind of looks like a corduroy appearance that we sometimes see inside the spine or vertebral body. And this corresponding MRI on T2, it showed that the majority of lesions is T2 hyperintense and has a filling defect from that internal septation. And then on post-contrast, it shows pretty homogeneous and strong enhancement. So this is a correct, pretty pathognomonic or classic for intraosseous hemangioma. So the lesion arises from the bony orbit. Next one, we have a young female who come in with left proptosis and blurry vision for the past couple of months. And then initially she got CT scan. And again, we find a pretty big expansile osseous lesions, but this time we have like a pretty dense sclerotic osseous lesions with a eldified or shaggy border. And it's involved the sphenoid wing on the left and also the lateral orbital wall, the superior and lateral orbital wall. And it's cause encroachment of the orbital structures in the left orbit. And in subsequent MRI post-contrast, you can see that in the area of sclerotic change on CT, didn't show much of enhancement, but we have an enhancement along the periphery of the lesions that look like a soft tissue plaque along both sides, intracranial surface of the lesion and also intraorbital surface of the lesion. So this is a classic appearance of the intraosseous meningioma. Next one, we have a 47-year-old woman who come in with gradual progressive left upper eyelid swelling over the past few months. And on MRI, let's look at the first row here. We have, on the top row, we have chrono T1 pre-contrast without fat sat. And in the bottom row, we have chrono T1 post-contrast with fat sat. And then look at the area of the asymmetry. You will see that it has kind of abnormal eldified lesion that center right in the area of the lacrimal gland. And just next to lacrimal gland, we have a kind of soft tissue lesion that in continuity with that lesion sitting on top of the area of levator palpebrae. So based on the anatomy, is just right at the exact location of the supraorbital nerve. So it's likely going to be patient have primary lesion at the lacrimal gland and then have pre-neural tumor spread along the adjacent supraorbital nerve and get back into the area approaching the orbital apex. So it could be a variety of tumors that start from lacrimal gland. Initially, we thought that it could be adenoid cystic carcinoma, pretty malignant tumor that can occur in lacrimal gland, and it has a very high incidence of pre-neural tumor spread. And this is the corresponding axial post-contrast image to show you that area of tumor and a little bit of some restic diffusion on DWI confirmed on ADC map. Patient underwent open biopsy by ophthalmologist, and biopsy proven to be extranodal marginal zone lymphoma of the lacrimal gland and has pre-neural tumor spread along the supraorbital nerve. This is the companion case, but this time it's a real adenoid cystic carcinoma of the lacrimal gland. But this lesion is pretty malignant and aggressive, so you can see that it's not only involve the area of lacrimal gland, but now involve multi-compartment of the orbit, including extracorneal space. We have corneal space and intracorneal space encase the optic nerve and has some mass effect on the optic nerve as well. And on the CT scan, there is pretty severe extensive destruction of the bone, and it starts to invade the area of the posterior ethmoid sinus as well. This is another case, old lady who come in with left proptosis that's noticed by her daughter. She denies any visual change or any pain. So initial MRI, it shows abnormal soft tissue mass that center at the inferior extracorneal compartment of the orbit, right? And if you look at the location, it's just right at the location of infraorbital canal. And likely going to be lesion that start from infraorbital canal and then extend into the extracorneal space. And it's caused significant mass effect. And you can see that the inferior rectus muscle is pushed upward. And now it's approached the optic nerve sheath complex, but there's still no mass effect or compression of the optic nerve yet. And then this is the T2 and then post-contrast. And this is the corresponding CT scan. It shows a nice evidence of the chronic bone remodeling and pretty abnormal widening of the infraorbital canal. So this is biopsy proven to be squamous cell carcinoma. And we thought that the primary tumor is probably arise from this skin, just right below the eyelid. And that is where the patient have a subtle skin cancer, and then cancer just spread back into the infraorbital nerve that supply in the mid-face, and then it get back into infraorbital nerve. And she just come in with asymmetry of the left orbit. Next is the classic example of lesion that again occur in the extracorneal space of the orbit, but this time it's just right at the area of lacrimal sac, right? And patients present to ED because of rapidly swelling and a rapid swelling of the orbit and have a fever and tender in that area. And you can see that on the CT scan with contrast, there is like a well-circumscribed cystic lesion with thick wall and surrounding inflammation with fat stranding. And that is a classic example of patients who have dacryocystitis with orbital cellulitis. And the corresponding MRI show you again kind of similar finding, cystic lesions, a lot of information around that cystic lesion, and it shows nice restic diffusion on DBY and low on ADC map. Next, this is a pretty unusual case that I got. Patient is the 88-year-old man who has a long-standing history of treated CA prostate about 13 years ago. And the initial diagnosis of his CA prostate is very localized disease, just kind of invade around the prostate gland. On the full workup, he didn't they didn't see any evidence of distant metastasis or any regional lymphadenopathy. So he got treated in that area of the cancer, prostatectomy, followed by radiation to the prostate gland. And then just 13 years later, he presented to ED because of the severe right eye pain for 3 days. And then he started to have some visual change. And on the initial MRI, it showed mass lesion that center at the area of the medial rectus muscles. And this pretty big mass has obliterated the adjacent intracorneal fat. And it started to compress and push on the right optic nerve sheath complex. And that's why he started to have some visual change on the right side. And because of given history of CA prostate, we metastatic cancer still in the top of the differential diagnosis. And that's what, after this MRI, he got biopsy and proven to be metastatic CA prostate. And then later on, he got full workup, and they used a PET MRI with PSMA to evaluate for distant metastasis. Somehow, that's the only site of metastasis that they found on PET MRI. So pretty unusual case, and have like a pretty stable disease of the prostate cancer, but later on present with solitary metastasis at the medial rectus muscles. This is a classic case of the thyroid-related orbitopathy or thyroid-related eye disease. So as you know, that is like to involve the belly of the muscles and spare the tendinous insertion, and somehow it's like to involve in order, like a mnemonic M slow. So you can see that it's involved bilateral sides of the orbit in the symmetrical fashion, and then it's mainly involved the inferior and medial rectus muscles. Other extraocular muscles also involved, but in much lesser degree, right? So this is the classic finding of thyroid-related eye disease. Another case with pathology in the corneal space, this is the young female who come in with diplopia or double vision for a couple that's been going on for 3 to 4 years. And on the clinical exam, she found to have the palsy of the left cranial nerve 3. And then on the MRI, it shows a symmetry of the extraocular muscles. And you can see that in the muscles that supply or innervated by oculomotor nerve, it shows some degree of atrophy. For example, of levator pulpebris, superior rectus muscles, medial rectus muscles, and inferior rectus muscles. So these are all smaller than the right side, while the superior oblique muscles spare and lateral rectus muscle also spare. So it's involved only oculomotor nerve. So when we investigate this case and look at the MRI, and if you look at further back into the area of cavernous sinus, you will see that she has a hypoenhancing elliptical shaped lesion inside cavernous sinus. And this is the corresponding coronal plane on post-contrast T1. And when you look back into the mid portion at the level of pituitary gland and pituitary stalk, it's just right at the location of the oculomotor nerve that's sitting at the superolateral corner of the cavernous sinus. So that's why she have oculomotor nerve palsy or compression. And this is a CT scan is performed as a CTA, but I'm showing you on the bone window that this lesion is heavily calcified. And on this coronal plane, it shows a very nice finding of the chronic bone remodeling. And if you look at the undersurface of the anterior process, you will see that it's flattened. So that means it's like a slowly growing lesion and start to cause some pressure effect to the bone and allow some time for the bone to remodel. So neurosurgeon perform open biopsy this lesion in the cavernous sinus, and it's proven to be calcified meningioma. Next case is a case who come in with the right side symptom with the right proptosis, and again, it shows like a classic finding of the intraosseous meningioma. That's like the case that I showed you before. But the lesion that I want to show you is on the left side. So this patient is symptomatic on the left side, and we just see this lesion that's sitting in the lateral intracoronal space of the left orbit. It shows intermediate to low signal on T1 and homogeneous high signal on T2. And when you give gadolinium contrast on the axial and coronal plane, you can predict that we acquire coronal plane first and then we acquire axial plane later, because you see that it shows a little bit of less enhancement and kind of heterogeneous enhancement on the coronal plane, and it's more homogeneous on the axial plane. So this is an incidental finding and is classic or finding of the cavernous venous malformation in the orbit. And intracoronal space is the most common location of this pathology. I think we're running out of time. Another example of intracoronal space lesion, this is a pretty extensive or sporadic schwannoma in the left orbit. And this case is multi-compartment, is biopsy proven to be IgG-related disease. And this case has the bilateral optic neuritis involved both sides, and now test is positive for MOGAD. And this is a case with perioptic neuritis, and on the full workup, she found to have viral infection in her CSF study. So it's associated with viral infection caused optic preneuritis. Another example of optic preneuritis, this case is caused by giant cell arthritis. So you see inflammation and enhancement and thickening of the optic nerve sheath, but not inside the optic nerve. And this is the classic case of optic nerve meningioma. So there's mass that occur along the optic nerve sheath and it causes compression on the optic nerve. And this is the last one, I believe. Patient come in with, it's a young patient who have bilateral optic glioma. So you kind of see classic finding of optic glioma in the setting on NF1. So it's pretty kind of fusiform enlargement of the optic nerve, and it has a tortuosity of along the course of the optic nerve as well. Just a little bit of enhancement or no enhancement on post-contrast study. And that's it. So in summary, every time that I teach my trainees about head and neck radiology, I emphasize of the deep understanding about the head and neck anatomy, including the orbit, when you want to interpret patients who have orbital pathology. And then you should understand the concept of orbital compartment, and then you will know, okay, where it's the center of the lesions and what is the potential diagnosis, and also like every other pathology that we use a lot of clinical context, the onset of disease and what is the clinical finding, and then you combine with what you found on the imaging, and then you should be able to come up with a potential differential diagnosis in that case. Thank you.